There seems to be a movement about to allow pharmacists to prescribe statins without involving a doctor. So what did I find out about this? Stay tuned to find out. So at first glance, we might suspect that this is part of a widespread conspiracy to increase statin sales. There's certainly motivation for that. For example, the Clinical Practices Guideline of 2018, 9 of the 10 recommendations are about statins, so they really just ought to call this a statin prescribing guideline as opposed to a guideline for the management of blood cholesterol. There's also certainly a financial future for statins, despite the fact that many of them, if not most of them, are off patent and can be sold as generics. Here is a prediction from a Yahoo article saying that the market will hit $22 billion per year by 2032. There's still plenty of money to be made on statins. I think that's overthinking it. There's a lot of journal papers and popular press articles about the topic, but as I looked into it more deeply, I think it's more of an outgrowth of something more fundamental and something more mundane, but in a way no less insidious. And that is society's unquestioning attitude about drugs being used to counteract our unhealthy lifestyles. In a sense, they don't need a conspiracy. The propaganda war is already won. You only have to watch the commercials on TV with the dancing ladies singing about lowering their HbA1c to see what I'm talking about. So here is one of those articles describing the supposed benefits of allowing pharmacists to prescribe statins. So notice that the emphasis is on statin use. The appropriateness of more statin use is never questioned. It's by now assumed to always be good. And I concede there are circumstances such as homozygous familial hypercholesterolemia where a statin use may be beneficial. The pervasive attitude represented here is that they're good for almost everybody. And the measures are often not even success in reducing cardiovascular events, but merely success in getting more people on statins. If you look at some of these statements here, the outcome measures related to statin use are used by several healthcare organizations. I did a video on that where Medicare reimbursements and bonuses can be based on not the results of giving people statins. Even the questionable one of lowering LDL isn't considered. It's just how many people did you get on statins. So that is the thought process that we're in. As it says here, financial reimbursement is tied to health system success in achieving clinical outcome metrics and best practice utilization. Those outcome metrics, again, are quite often more people on statins. So the highlighted section I have here from this paper, clinical pharmacist interventions have been associated with improved clinical outcomes related to cardiovascular risk factors. It doesn't say cardiovascular risk events, but risk factors, and adherence to chronic medication therapy. Health systems are utilizing clinical pharmacists to improve statin use measures in diverse ways. So you notice again, the emphasis is on improving statin use measurements. And by improving, they mean increasing. If pharmacists are prescribing statins, will they tell patients about what the real benefits are in a statistical manner? I mean, given that most doctors don't, I don't see how pharmacists are going to do it, though they may actually have more time with a patient than a doctor will. So let's look at a typical situation and how we could describe it and frame what we say to the patient to achieve whatever our goal is, whether it's to talk them into taking statins or talking them out of taking statins. So here we have a typical situation, maybe a patient with a 20% 10-year risk, and you can make comparisons in different frames of reference. For example, this chart on the right shows untreated, and you'll see why I have the red part labeled A and B in a moment because I'm going to break it into two components. The red area here represents the percentage of people who will have a cardiovascular event, they're left untreated, and the yellow is the people who will not have cardiovascular event if they're left untreated, and this is a 10-year time frame. So we would tell the patient, well, there's a 1 in 5 chance that you're going to have a cardiovascular event in the next 10 years if you're untreated, and that's comparing the A and B block with the totality of all of it. And that's a 20% 10-year risk of a cardiovascular event. And that may scare somebody. Somebody may look at that and say, yeah, I should get that treated. And I wouldn't blame them for thinking that, even though there's a 4 out of 5 chance that they won't need it, but still rather high. But another way, we could turn it around and say, well, there's a 4 in 5 chance that you're not going to have a cardiovascular event in the next 10 years if you're left untreated. And that's just comparing the block mark C with the totality of all of them. But another way of looking at this is to just look at the people who are going to have a cardiovascular event if they're left untreated. Will we ever point out to the patients that there's a 1 in 7 chance that a statin will actually prevent a cardiovascular event if you're otherwise bound to have one? That's the 14% relative risk reduction that might be typical of patients with a 20% 10-year risk. And that's comparing the green area to the red area. And somebody looking like that might say, well, that's better than nothing, but at least they wouldn't get a false sense of security that if they take this medication, they're going to be protected for sure. It's actually fairly unlikely that the treatment is going to avoid a heart attack for them. The other way of looking at it is there's a 6 in 7 chance that you're going to have a cardiovascular event even taking the statins if you were otherwise bound to have one. So that's comparing the red with the combination of the red and the green. So let's bring back everybody else into this. And another way of looking at this exact same data is absolute risk reduction for using a statin is 3.4%. That's comparing the little green rectangle up there with the whole population represented by this chart or this graph. And then we can turn that upside down on its head and figure out a number needed to treat and say there's a 1 in 29 chance that the statin will prevent a cardiovascular event for you. If you put them in these terms, some people undoubtedly will say, well, yeah, okay, I'll still take it. And other people will say, well, no, I don't want to take it. And I'm not even getting into the whole area of adverse effects. That's a whole nother area where we would have to trust the pharmacists, like we trust the doctors, to give the patient an honest assessment of those things. So there is so much material on this topic in so many different jurisdictions, different nations, different regions within nations that all have different rules. I decided that all I could do was zoom in on one particular case study. And the case study I chose was the Idaho Pharmacist Prescribing Rules. Now, if you're not familiar with Idaho, if you're not familiar with the states of the United States, Idaho is a northwest state. It is a rural area in general. Overall, it's a rural area. Sparsely populated, but I wouldn't say it's unsophisticated. The legislators there came up with a rule allowing pharmacists to prescribe certain medications, and I think they did a pretty good job with it. So let's take a look at that. In 2019, they had a House bill. They have a bicameral legislature, I believe, with a House of Representatives and a Senate, just like the United States in general. And they amended the practice of pharmacy to mean the prescribing of, or to include, we're interested in this particular subparagraph 5G, to include the prescribing of drugs. And these are the conditions. They don't require a new diagnosis. The pharmacist isn't going to diagnose the patient, but they may recognize appropriate treatments for patients who are already diagnosed, or they're minor and generally self-limiting conditions, for example, strep throat or something like that, or they have a test that is used to guide diagnosis or clinical decision-making and are waived under the Federal Clinical Laboratory Improvement Amendments of 1988. Now, that's a mouthful, and that needs some explaining here. Having a test that is used to guide diagnosis. Well, in the case of statins, it might be a lipid panel. In the case of type 2 diabetes, it might be an HbA1c test or a blood glucose test or an oral glucose tolerance test. And this part about being waived under the Federal Clinical Laboratory Improvement Amendments really just comes down to meaning that tests that are so ordinary and not very technically complex that they're considered safe and they've got a waiver against this Clinical Laboratory Improvement Amendment. That's, I guess, a federal amendment. So that's the category under which statins are generally going to be prescribed if they're going to be prescribed under this law. And then finally, 4, I just wanted to cover this one just to show how the legislature's thought process is. In the professional judgment of the pharmacist, threaten the health or safety of a patient should the prescription not be immediately dispensed. So what I thought of in this case is there's some local flooding going on, which makes getting around very difficult. The only medical facility of any kind around it is just the pharmacy that a particular patient can get through to. Foamy, the town raccoon, bit them and they're afraid of getting rabies. Well, if they went to the pharmacist and the pharmacist knows they can't get to a hospital or to a doctor for a few days, it might be appropriate to give them a rabies vaccine if there's any on hand. That way the pharmacist isn't put into the ethical position of saying, no, you're going to die from rabies because I'm not qualified to give you what I have here on the shelf. There is a document that has the standard of care called out on it. And it points out that the Board of Pharmacy, that is a government entity within Idaho, go on to say here, thus, rather than specifying in law which tests are needed or what referral thresholds must be followed, the Board of Pharmacy adopted a standard of care approach. This just makes it easier for the Board of Pharmacy as a legal entity within the state to specify what can and can't be done without them having to go back and change the rules all the time. They're going to reference the standard of care model. There's a table in the same document. Here are some excerpts from it, which specifies the drugs and devices that Idaho pharmacists may prescribe by rule. Under gaps in care, they say statins for patients who have been diagnosed with diabetes. That is the only reference, this first one that we already saw, and this one. These are the only references to statins in this entire write-up by the Board of Pharmacy. But these are the only places that statins are called out. So if we think that, oh, there's legislation around to allow statins to be pushed everywhere, it's not really that. It's just one of the many medications that might fall under this rule. What I was surprised is not to find metformin in here, because I would have thought that a pharmacist could maybe prescribe metformin to a type 2 diabetes patient. I couldn't find that in this table. I did find, though, that a pharmacist could prescribe a continuous glucose monitor, and that makes a lot of sense to me. So when I look at the intent of this law, I think it's actually very good. It's to get better care to people who are going to need it. Unfortunately, this use of statins for people with diabetes snuck its way in there. So for my closing thoughts, we shouldn't be too paranoid about the intent of the legislators in expanding the role of pharmacists in prescribing statins, because for the most part, statin component is just one in many situations, and the legislators were probably not thinking of that specifically. It's not like there's a statin-specific movement here, but there are two important points. Most of the commentary I found on this indicated there are efforts to use these general laws by the pro-statin advocates to increase statin use with the unquestioning approach that the guidelines are gospel and there's the need to get all eligible patients actually taking statins. That ignores two very important things, and that is that they're applying population statistics to individuals again. A prescribing pharmacist is not likely to be able to make that distinction and discuss those things with the patient the way a doctor should be doing. And also, it ignores the patient's values, such as their risk tolerance and the patient's susceptibility to adverse events. Now, another problem with this Idaho rule, which I've already kind of alluded to, in this Idaho rule in particular, but a lot of others, is this notion of treating type 2 diabetes patients with statins. Smoking, hypertension, type 2 diabetes, even according to the standard risk calculators, have more impact on cardiovascular event risk than does LDL, which is what the statins are supposed to treat. So often on this channel, I will grant mainstream medicine their assumptions for the sake of argument to illustrate a point, and this is one of those times. Even if LDL is a risk factor by their own calculations, it's the fourth in impact behind these other three that I've mentioned. They're saying you have type 2 diabetes, and that's a major risk factor for cardiovascular events. So we're going to treat you by giving you a drug that is likely to make your type 2 diabetes worse, but it'll partially offset this other lesser risk factor. And that's the one guideline recommendation they will allow pharmacists to consider in this Idaho interpretation of the law. The law exists. The Board of Pharmacy adds the details to tell pharmacists what they can and cannot prescribe. So I know there's viewers out there who are going to say, yes, but the actual benefit of statins is from the anti-inflammatory effects. And whether that's true or not, the intended therapeutic effect of statins is the lowering of LDL. Type 2 diabetes should be a contraindicator for statins. It's not the reason to give them, yet that's the single guideline that the Board of Pharmacy wants pharmacists to follow in Idaho. So I'll let that idea speak for itself. So that's what I have on this topic. If you appreciate this content, please like, share, subscribe, and comment on this or other topics you'd like me to discuss. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.